increased intracranial pressure. So this is all just like a big circle of care. So this could be your baby in newborn nursery. So you're assessing the fontanelle. You know, you're looking for normal facial features to determine did something happen. I mean, if this was a complicated delivery that kind of, you know, the baby came around quickly in the delivery room and then went to the newborn nursery, you're still assessing for all of this. So that newborn assessment is so important. You know, when a baby comes to the NICU, all of them, anything over 32 or under 32 weeks is getting a head ultrasound. We're going to know our information. But in the normal newborn, they're looking for signs and symptoms and assessing, which we saw abnormal newborn exam that was a rule out seizure, and it definitely abnormal. I mean, there's nothing normal about the exam. So it's very important to know the normal to the abnormal. IVH, intraventricular hemorrhage, is rated 1 to 4, and 1 has a good prognosis, 4 has a poor prognosis. Bilateral grade 4 intraventricular hemorrhage is incompatible with, it can be withdrawal of life support. Once the baby has an intraventricular hemorrhage and has bleeding into the ventricles of the brain, the concern is that the clotting of that blood in the brain causes, you know, an imbalance of the cerebrospinal fluid. I mean, causes. But once that blood goes through, if it doesn't clot and that bleeding doesn't stop in the ventricle, it spills over into the brain tissue. That's when you determine a grade 4. Because once blood is on the brain tissue, it dissolves it. There's no fixing it. There's nothing anybody can do.
What if by ultrasound, right?
Ultrasound.
The blood dissolves the brain tissue?
Yes. It turns it, it liquefies it.
Oh. Is that just if babies or if adults have intracranial breathing, will it do that too?
I believe it's with everybody, especially in babies.
That's what floated into the brain.
Brings on to because it's
The nerves and stuff.
these are just real basic
not the nerves, but
understanding
they don't
IVH,
clot.
which is all of ones.
Your brain
There's some
tissue
risk factors.
Super vascular.
So if it starts bleeding,
So
and
why
it just
would
sits
it
there.
dissolve it?
It's just sitting on the brain.
Oh.
So just like,
At that point, if you decide to go on with a bilateral grade 4 hemorrhage child, you're gonna keep the baby and continue as long as the baby makes it. They put a shunt in so that that fluid has a passageway to at least function between the brain and the spinal fluid. And causes, I mean, common sense. What do you think could cause an intraventricular hemorrhage?
Birth trauma?
Birth trauma, prematurity, infection. So there's a lot of different things. Okay, so IVH occurs when small blood vessels near the ventricles break. The highest risk for IVH in babies born more than 10 weeks early, so less than 30 weeks. So under 32 weeks is getting a head ultrasound. Many babies with IVH do not have symptoms. This is in the normal newborn nursery. When symptoms do occur, apnea, low blood pressure, slow heart rate, decreased tone, and seizures. So, even though Dr. Singal wasn't convinced something was going on with that baby that we saw presenting, with just tremors off the bed, weird head movements, look at how many, you know, decreased or increased muscle tone, seizure-like activity. I mean, the baby had some things that didn't look right.
Will this occur with people who are babies that sustain trauma? Like babies that have gone home, I know we're talking about the newborn, but babies that have gone home and have like had shaken baby syndrome.
Yes.
That's not caused anymore.
I think it's in a different area with shaken baby.
Okay.
But it's, I would imagine, yes, because once that blood gets on that brain tissue from a hemorrhage, wherever it will blow to the head, or you're gonna have swelling and issues. So the baby can breathe, has a heart that's functioning, can stay warm, and what was 4? Eat.
Nutrition.
Okay, so number 5, establishment of waste elimination. They have to poop. Anybody who was in a newborn assessment, down at L&D, right on the top of those cards,
Oh, yeah.
patent anus.
Oh, yeah.
Right. So the baby has to be able to poop, because everything's still looking great in the delivery room. Baby's pain, crying, whatever. You get him over to the radiant warmer, and you do that first check to make sure your butt's open, and it's not. So surgical intervention immediately. So,
Does that happen frequently?
not that frequently, but it does happen. Thinking of the high-risk infant, the most common thing in a premature infant related to elimination is something called necrotizing enterocolitis. It's an acute inflammatory disease of the bowel in preterm and high-risk infants. Factors developing in development: prematurity, interstitial ischemia, colonization of pathogenic bacteria. They really don't know exactly what causes NEC and who gets it. But it is bad. It progresses very quickly. Normal assessment at 8 a.m., wildly abnormal assessment at 11 a.m. It hits that quick.
What sort of symptoms would you see?
They have abdominal distension. Often, the first thing you see in a premature infant, though, is you pull, when you go to check a feeding tube before they eat, you push a little bit of air and you pull it out to make sure you can hear where the tube is. You go to pull out and it's green. Bilious aspirate is usually your earliest. Every baby that's being gavage fed, every single feed, and nobody ever skips it, is an abdominal circumference. Because even a slight increase in abdominal circumference, meaning something's starting to swell in there, or there's trapped air, or there's something going on, is a symptom. Again, sepsis. This baby's septic, so the temperature will start to drop. But usually your bilious aspirate is your first indicator that something's not going right. Then you check your abdominal circumference and it's up 1 centimeter. Then you check your thermometer, your temp is below 36.3, so below that 36.5 range. And at that point, you're telling the doctor, I've got
And
these
as
findings.
that abdomen gets bigger and bigger, it pushes up against their lungs, so they're having more difficulty breathing.
Breathing.
So one thing leads to another.
Mhm. And so you'll often see the nurses just talking amongst themselves. You know, I got a little bit of aspirate. I'm not sure if I should call the doctor. And anybody who has any experience says,
Call the doctor.
What they'll do is they'll do a CBC to see if there's anything changing on the CBC and an abdominal x-ray. They can see on an abdominal x-ray that there's air or a blockage where there's stool or gas up here but nothing down here. So that means that that section of bowel is inflamed or something's going on. In a rapidly progressing necrotizing enterocolitis, that will go from just inflamed and whatever, and the intestine will perforate open, and then you have a peritonitis. You have
This section of the cat, like the cat.
yes. Pardon?
No.
Yeah. Triple antibiotics and off to children's for surgical intervention. And they will do little colostomies wherever they need to get the bad bowel out.
I don't know, if it was.
So, babies don't eat for 24 to 48 hours. You put an NG tube or Repogel to suction, decompress the stomach, IV antibiotics, IV fluids, hyperel once they can initiate nutrition, and surgical management may be needed if perforation of the bowel. And it is definitely life-threatening. This is as soon as the doctor says it's neck, call the parents in because you just don't know which way it's going to go. The next high-risk thing we're going to cover is ROP. It's retinopathy of prematurity. It is an eye issue. What was discovered was that hyperoxygenation of newborns causes the retina to mature too fast. So in a premature infant with a retina that's growing and going forward too fast can cause blindness in premature infants. And you are all probably too young, but 20 years ago, if you had a premature infant, they had coat bowels this thick. I mean, it was the only, if they weren't blind, they had really bad vision.
Huh.
So what they found is that with intervention, decreased oxygenation, and following up by pediatric ophthalmologists, they're saving these sites. What they do is once the retina starts getting like it's growing too fast, they take a laser and they start cutting it back a little bit, and then it slows to the progression of a normal, developing eye. And you can have micropremies that do not need glasses. So that is a great thing. But the link of excessive oxygen and retinopathy of prematurity is the big thing. Decrease the oxygen. The oxygenation causes the stimulation of the cells in the retina, which would start growing too fast because they would have been in a completely darkened environment for 40 weeks. When they're born at 24 weeks, they're in a bright light, environment, and their eyes start developing too soon.
So that you're blending the oxygen now not to have 100% every
Mhm.
time you resuscitate.
Yeah. So any infant or baby, newborn or preemie, will not be in 100% oxygen unless they need it to stay saturated. If a baby's in room air, it is 100% of the pulse ox. That's normal. There's nothing you can do about it. But if they're getting supplemental oxygen, you want to keep their oxygen sats at 97% or less. If the baby's greater than 32 weeks, it's 92 to 97. That's more detail than you probably need to know. And if it's babies below that gestation, it's 88 to 92, just to prevent that hyperoxygenation and the complications that come along with it. Preterm skin, obviously very fragile. Newborn skin, keeping it always moist. The high-risk infant, when you think about skin care, is obviously we do go right to the preterm because they don't have that line of defense for infection, for thermal regulation. So, prevention of infection. This goes full term to microframing. Neonatal sepsis. So early onset sepsis is 1 to 3 days of age. Late onset sepsis is 1 to 3 weeks of age. So most common causes are Group B strep, which is super important information. It's what they're asking as soon as they get into L&D. They're looking for prenatal records. They want to know about Group B strep. Listeria, staph, strep, and Haemophilus are all common causes of sepsis. A nosocomial sepsis can be staph epidermis, Pseudomonas, Klebsiella, Serratia, and Proteus. So skin cleaning for any IV sites. Use alcohol. Hand washing, gloves, super important to prevent neonatal sepsis from nosocomial causes. Maternal conditions, obviously you want to know if mom has a choreo amnitis, if she's Group B positive. Back to the immunizations, is she at risk for any illness? Was she febrile? Are her kids at home all having the chicken pox and she never had them? Whole list of information that you need to know to prepare and to start early treatment for sepsis.
If you get Group B strep, I just feel like we see this everywhere.
Mm-hmm.
So you would do a blood test on the mom to see if she comes back positive for like a history of it, right?
No,
It's a
not a
cervical.
blood test. Remember, that's the one that we do the vaginal and slide it into the rectum.
Oh, yeah.
The
So what sort of symptoms did you have if you had?
mom carries it, doesn't even have a symptom.
Oh.
That's the worst. That's the problem, and that's
Yeah.
why it's a routine check at 36 weeks.
Oh.
Yeah, because mom can walk around with it and it's not a problem. But she's a carrier, and as that baby comes through the birth canal, then the baby gets exposed, and then it can end up with neonatal sepsis.
So mom is treated
Mom's treated.
with antibiotics.
Right.
And you want to keep that baby inside for at least, you try to get a couple doses, and that's kind of like what we try to do.
And
And
so
then
the
would you
newborn-
treat them if you don't have time to treat the mom with antibiotics?
They will watch that baby very closely. They may not automatically treat. They'll
Okay, that's
probably do cultures of the baby, and maybe even surface cultures, but they say the surface cultures really are negligent.
Okay.
So 36 weeks.
Negligible is what I should say, negligible.
So 36 weeks is when you test for Group B strep. So we have the baby born at 26 weeks. All newborns get Ampin Gent in the NICU. It was enough to quiet the Group B strep. Mom had never been tested, and at about 21 days, 21 to 28, the baby presented with a full-blown Group B strep infection. It was critically ill. She was that little one in the cribette towards the end of the NICU nursery. It was like a bigger raised
So
crib.
that it got treated, but still got it?
Mom was never treated because she didn't have prenatal care, and she delivered at 26 weeks.
But the baby wasn't treated automatically, prophylactically, or no?
No,
I
because
thought
it
that's
is,
what I heard you say.
we didn't know she had group B strep. It was never,
No, nobody would know.
yeah. And the baby got ampicillin and gentamicin, which is the normal for all babies coming into a NICU,
That's what
but
I was
only
wondering.
for 48 hours.
Only 48 hours worth?
Yeah, the blood culture was negative. For mom admission, they grow for 48 hours. If it's negative 40 hours, they discontinue the antibiotics. But the lab continues to watch that for 7 to 10 days or
Yeah.
however. Nothing showed up, and then I can't remember if it was 21 or 28 days of life. The baby just crashed, just absolutely crashed, and it was immediately positive for beta strep.
Mm.
So, earlier testing, I don't know. All right, beat it. Hypothermia is a sign of sepsis. Maternal history is very important. Treatment, antibiotics. Could be ampicillin gentamicin, could be vancomycin, could be anywhere from 7 to 21 days for the sepsis, depending on the organism. Seventh priority, and there's only 8, we're almost done. Establishment of an infant-parent relationship. So, infants of diabetic mothers, they're often large for gestation. One of the most important nursing actions of an LGA newborn is the close monitoring of glucose levels. What happens when you're constantly testing the glucose level? You're taking it, the baby away from the mom. So that's why I chose to put this under the maternal infant bonding. Okay, babies that have unstable glucoses down in labor and delivery get taken up to the newborn nursery right away. You've got that no kangarooing, so there's that impairment. Even though the best treatment for infants of diabetic, mothers for the baby is early and frequent breastfeeding and kangaroo care, as soon as that baby has a low glucose, it was getting taken to the newborn nursery or the NICU to be managed. So that is an important maternal, much better now that we've got that new glucose meter that we can hold, because we can manage it a little bit quicker. We don't have to run out to a separate machine and test it. It's be right at the bedside, and the results are like that. So if the glucose starts trending low, get mom to nurse. If she's not nursing, offer formula and try to get through that hypoglycemia. We've talked about, enough that the baby gets the glucose but not the insulin from the mother. The baby has to produce the insulin. Clamp that cord, sugar ride is over, so you have to see how the baby's going to transition. Is the balance, the insulin glucose balance, what's it going to do? A normal transitioning baby gets clamped and has a little bit of a dip, 1 to 2 hours, but then steadily increases on its glucose of its own blood. It's metabolizing brown fat, it has a little bit of store of glycogen in the body and can get through transition normally. The brain is the only organ that does not have a glucose store, so once the baby becomes hypoglycemic, if it doesn't have a brown fat store, if it's not metabolizing glycogen well, that brings it to, at risk. So, knowing that glucose level and watching for signs and symptoms of hypoglycemia, which would be a jittery baby, a cold baby, a stressed baby, is imperative to get the baby through that. If you can initiate early and frequent feeds and put the baby skin to skin and provide a decreased stimulation environment, that baby can sometimes transition and metabolize itself. But you're going to monitor those blood glucoses hourly for 4 hours and then before feedings for 24. The AAP's guideline for a level of glucose and a value, the best they can come up with is 45, and greater is normal. After 24 hours of age, a baby's glucose should be higher than 50. And the reason there isn't a real defined value on that is because there's no randomized controlled trials where you're going to have some kids be low, some kids be treated. Okay, so that's that. Infant diabetic mothers have respiratory distress. This is